Good evening and welcome to Dosimetry 322. My name is Brian Hall, and the case study that I am going to present to you today is on the pancreas. So I'm going to start my presentation with a little bit of anatomy and physiology of the pancreas. I'm sure that most of us, or all of us, have actually had anatomy and physiology, so this is just a quick review. The pancreas is an important accessory organ located behind the stomach. It manufactures, holds, and secretes digestive enzymes. These enzymes include pancreatic amylase, which breaks down carbohydrates, lipase, which breaks down fats, and proteases, which breaks down proteins. Beta cells release insulin, which initiates glucose uptake by the cells and tells the liver to store glucose as glycogen. Alpha cells work in reverse compared to the beta cells because it releases glucagon, which tells the liver to take stored glycogen and convert it to glucose for energy. So the pancreas is a really important organ in the body, and it's an important organ in the endocrine system. So it's vital that the human body actually has this, because we need it on a day-to-day basis to, like I said, break down foods for energy, and it releases hormones. It's a hormone manufacturer for a lot of the processes that the body goes through. So, a little bit on the patient history and physical. On August 9th of 2013, a 71-year-old female came into the walk-in clinic with the chief complaint that her stomach did not feel well, and she has lost 9 pounds over the last month. CT of the abdomen was performed, showing a strictured area with abdominal mucosa at the first and second junction of the duodenum. Additional findings showed a 6.5 centimeter ill-defined mass with some central necrosis centered between the third portion of the duodenum and the head of the pancreas. So, given the CT that was just done on August 9th of 2013, a biopsy was performed and revealed a poorly differentiated adenocarcinoma with no distant metastasis. And in reading the H&P from the physician, it was highly suspected that she was going to have distant metastasis, but apparently in the diagnostic CT they didn't see anything. In these two images here, I have pointed out the duodenal pancreatic mass that's inside this patient over here in these cross-section views of the CT, and you can see that they're quite large, anywhere from 5 centimeters to 6 centimeters, depending on where you're at within the body and given the anatomy. And this is just another slide of the cross-sectional anatomy done with the CT, and on the right there I have the tail of the pancreas actually pointed out, and then on the left is the tumor and disease. Now, in reading the H&P, it was hard for them to define whether or not the primary tumor was indeed found in the duodenum or the head of the pancreas, but they were leaning towards the duodenum, so this is a duodenal pancreatic cancer. So after giving the biopsy and her prognosis and everything, they decided with the patient care plan that she would undergo a palliative gastric jejunal bypass, or a gastrojejunostomy. And this is quite a fascinating procedure where they will basically disconnect the stomach from the duodenum and then close up that duodenum section and connect the head of the pancreas into the duodenum where the stomach actually used to be, and then reattach the bile duct from the liver into the duodenum, and then on the second portion of the jejunum they will create an anastomosis and attach the stomach there. So it's quite fascinating procedure. It's very invasive. It's got a lot of risk associated with it, but in this case it seemed to work very well with the patient. And so this is post-gastrojejunostomy. This is just a CT done afterwards. This is basically the contrast CT in which we used for our treatment planning process. I have highlighted on both cross-sectional, well, one's a cross-sectional view and the other one's the coronal views, the stomach and the pancreas. And if you can think back to the last slides, it's quite significant as far as the difference from then to now. There's the stomach there on the top image that I have highlighted, and then down below that, right underneath the stomach, is the pancreas itself. Along with the gastric jejunal bypass, FOLFOX chemotherapy regimen was also given to the patient, but because the patient was intolerant to it, it was actually discontinued. The new plan for the patient was then to administer radiation therapy as more of a local control with radiosensitizing 5-FU or Xeloda. Like I said, the overall plan for this was just to improve local regional control and hopefully favorable impact median survival. Patient was then simulated using a CT scanner. 2 CTs were performed, one with contrast and one without, for radiation treatment planning. Standard immobilization devices such as a wing board and upper back lock were both used in order to carefully reproduce the patient's position on a day-to-day basis and actually keep them in more of a stable or still position throughout their treatment course. A dose of 50 gray was prescribed over 25 fractions, 200 centigrade per day. The physician, when I was approached to actually plan this, asked that he wanted to see 2 plans, one IMRT and the second being a 3D conformal, but in the end I ended up with 3 actual plans. So I'm going to go through all 3 plans, just a quick synopsis of each one and what each one had to offer and which one actually was the best and where the pitfalls were in these 3 plans. Segmentation and the organs at risk were the right kidney, left kidney, liver, small bowel, large bowel, stomach, cord, and the PTV 5000. And over on the right there is a picture of all the OARs and things that were contoured within the body, just all the various structures for this treatment plan. So we're going to start off with the 3D conformal plan with MLC blocking. The arrangement of fields was an AP and right and left lateral. The laterals had a 30-degree wedge, a dynamic wedge, and the AP had a 15-degree dynamic wedge. Equal weighting on all fields, and the energy was an 18x, and there was a 0.7 centimeter margin around the PTV 5000. Here's a slide of the beam's eye view for a lateral and the AP of the 3D conformal plan with the 0.7 margin around the PTV 5000. You can also see the cord in these images also with the right and left kidney. So this is an image of the completed 3D plan. You can see that there are wedges on the left and right lateral and on the AP field. The wedges on the left and right lateral, they actually help to push the dose from the anterior aspect of the treatment volume to the posterior aspect of the treatment volume. And the AP wedge actually helped to push the dose from the inferior aspect of the treatment volume to the superior and posterior aspect of the treatment volume. There's also on the left side, you can see a little bit of high dose region over there. And in selecting the wedges for this plan and adjusting the weighting and things like that, this is what I ended up with. If I were to adjust the weighting back and forth, trying to get that dose out of there, it would actually pull away from the total coverage of the tumor volume. So I figured that that was probably a decent enough compromise. This plan does cover the tumor volume by the 100% line, so it is totally encompassed by the prescribed dose by the physician. So it's all in all a decent plan. But over there on the up right side, you can see the DVH, and it's just kind of things are just everywhere, and there are some high dose regions, especially in the kidney region. So I'm also going to show later a comparison with all the DVHs side by side. And this is just a quick snapshot of the DVH for the 3D conformal plan. It's just a larger view of it, and you can see the hot pink there on the very top right. It's actually the total coverage for the dose, for the prescribed dose given by the physician, and it does cover the treatment volume, but everything else, like I said, is kind of sporadic, and a lot of the other tissues have, some high dose regions. So, like I said, I'm going to show the comparison of the DVHs in later slides. And so the next plan is full arc or rapid arc. It has 2 full rotational fields, and it uses the VMAT optimization tool to put constraints and things like that on the organs at risk and target volumes and things like that. And so this is an image of the finalized full arc treatment plan. In the middle there you can see the PTV 5000, and it's pretty much encompassed by the entire 100% line, in which in fact it is. There are some 106% in there too, which is the light teal there, but that's acceptable because if you're going to have a hot spot, you might as well have it in the targeted volume that you're treating and not outside the targeted volume. Also, you can look over at the DVH real quick, and if you have a pretty good memory and you remember the last slides and you saw the DVH from the 3D conformal, you can see how these isodose lines, or this DVH schematic is actually a lot closer as far as the doses aren't all over the place, and you see more of a conformal dose, or at least tissue sparing as far as that's concerned. And so this is just another snapshot of the full arc rotation, the DVH, and like I said, I will show a DVH comparison of all three of them side by side, but this is just a larger view of the last slide. And so this is the starting of the partial arc rapid arc therapy plan. It has two partial arcs starting from 30 degrees to 181 degrees, and then back from 181 to 30 degrees. And it used the VMAT optimization tool. And so here's an image of the finalized partial arc plan, and you can see that the dose is actually just like the last one, the full rotation arcs. It does cover the entire treatment volume by the 100%. The isodose lines are a little bit different, or the DVH lines are a little bit different as far as overall tissue sparing. And because it's partial arc, because the left kidney is now no longer in the treatment field itself, the overall kidney dose is less. However, in the constraints and boundaries when creating this plan, there had to be pretty strict constraints for the right kidney to actually try to spare it as much as possible, or at least keep it out of the high dose region. And you can see there's the teal isodose line on the upper right hand corner traversing through the right kidney, and you can see how it's curving up in there and kind of avoiding most of the kidney, and that's due to the boundaries and the constraints that are actually put on this. It actually sucks the dose in. The algorithm is working pretty hard for this to actually avoid the kidney as much as possible, and also keep the integrity of the prescribed dose to the overall treatment volume. And so here's just a quick snapshot of the partial arc DVH, and you can just see how the DVH lines they're becoming more sloped, and which is a good thing, and that just means that the overall dose to the various structures is actually reducing. So this is a slide containing all the DVHs for all the plans that were done. The top left is the 3D conformal DVH, and then going towards the right is the full arcs, and then down at the bottom is the partial arcs. You can see that the 3D DVH, now that all of them are side by side, it looks quite sporadic, and dose to different structures is quite different than the other two plans. The kidney dose on the 3D DVH is somewhat higher than the rest of them, which is the teal color. But looking at the full arc versus the partial arc, I mean, a lot of the doses there look fairly similar. You can look at the yellow, which is the cord dose, which is fairly similar. The kidney dose is also fairly similar, especially for the right kidney. However, if you look at the left kidney, you can see that the doses there are different, and that's due to the partial arc avoiding the entire left kidney and actually sparing that. So all in all, as we go from the 3D conformal plan to the full arc to the partial arc, so far it looks like the full arc and partial arc are the winners of all the plans, but there are slight differences amongst the full arc and partial arc, which one stands out and which one makes, which one's better. And so this is a slide on the DVH comparison according to the RT-OG 0848. You can see that there are various colors on this chart. The red meaning the last or the least best plan, and the yellow is the second best plan, and the teal color is the first best plan. And looking at the right kidney, you can see that the constraint that was there stated that 50% of the total volume should receive less than 18 gray, and the 3D with MLC blocking just met that constraint, but the full rotation rapid arc actually won with 39%. And then going to the left kidney, you can see that the winner here was the partial rotation rapid arc, and like I discussed earlier, it's because it was partial arcs and not full arcs, so it actually avoided the left kidney a lot more than the rest of the plans, and the constraint there was the same as the right, with 50% of the total volume receiving less than 18 gray, and so the partial arc was 4.5%, the 3D was 12%, and the full rotation was 33%, and it was 33% because it was full rotation arcs, so it obviously, it hit the left kidney in its path of rotation around the patient. Looking at the liver there, it's supposed to have a mean dose of less than or equal to 25 gray, and all of them met this constraint. However, the partial rotation rapid arc actually was the best in this with 11.54 gray, but it wasn't much better than the full rotation with 11.55 gray. The small intestine, the volume, 50% of the volume was supposed to receive less than 45 gray, and all of the plans actually met the constraint, with the full rotation and the partial rotation being the same with 0.2%, and the 3D being 2%. Looking at the bowel, 50% of the volume was supposed to receive less than 60 gray, and in fact all the plans met this, but the partial rotation arc actually had the best with 13.28 gray, and the 3D with MLC blocking was the worst with 32.47 gray. Looking at the constraint for the stomach, 15% of the total volume is supposed to receive less than 45 gray, and you can see that the 3D with MLC blocking actually did not make this constraint. The volume receiving 45 gray was in fact 20%, so 5% higher than what the constraint wanted. But looking at the other plans, you can see that the full rotation rapid arc won in this case with 9%, and the partial rotation rapid arc had 9.9%. Moving on to the cord, you can see the max dose to a point, or 0.03 centimeters cubed, is less than or equal to 45 gray. All of them actually met this constraint, but you can see that the 3D with MLC blocking actually won, and this is due to the fact of the field arrangement, the two laterals and the AP. It didn't have a PA, so therefore it spared the cord a lot more than the other ones, especially with the full rotation, because it was two 360-degree arcs all the way around the patient, so avoiding the cord wasn't really an option there. But the partial arc actually did avoid some of the cord, but still it wasn't much better than the full rotation rapid arc. So at the bottom there, you're looking at the PTV 5000, which was the prescribed dose, and you can see that all of them actually met it. The 3D conformal plan had a max dose of 49.2 gray, and the full rotation rapid arc had 55 gray, and the partial rotation rapid arc had 56 gray. So the plan that was actually chose was the partial arcs. It was chose because it had better sparing of tissues, which will hopefully reduce the side effects. It also covered 100% of the target volume, which that's what the physician had wanted to happen in the original prescription. And also it was chose because it would allow for less time for the patient to be on the table, so for less likely that the patient would be able to move during the course of treatment time. So because the plan that was selected was the partial arcs and it was IMRT, all IMRTs have to be QA'd, and in the facility that I'm at, we use MapCheck. And according to the MapCheck QA, it showed that it had a 95.6% pass rate, but it also can be seen that in general, the agreement was within 2% of the expected values from the treatment planning system. So after this was done and it was accepted and the doctor signed off on it, it was then implemented so that it could be used in the treatment for the patient. And some of the side effects for this treatment include nausea and vomiting, diarrhea, fatigue, poor appetite, weight loss, and lowered blood counts. During the treatment for this patient, she experienced diarrhea as a result of treatment, and she became extremely dehydrated, and fluids were given on several occasions. She was unable to eat due to an upset stomach and poor appetite, and even stopped taking her Zolota during the course of treatment. She was given anti-nausea medicine to help her with that, so that she would actually continue to eat during her course of treatment. The patient was treated on a TrueBeam linear accelerator. Cone beam CT was ordered daily for accurate setup and delivery of treatment. Radiation therapists were given instruction with proper day-to-day alignment of anatomy, which included the bony anatomy, celiac artery, and superior mesenteric artery. Patient was instructed to have an empty stomach prior to treatment every day. Prognosis of the patient. Like I stated in the earlier slides, the overall plan of care was palliative treatment for this patient. Hopefully with the gastrojejunostomy and radiation, the patient will have local control and a prolonged life. Difficulties I had with planning. The most difficulty I had, I think, was with the 3D plan. It was trying to set up the arrangement of treatment fields and making sure that I was avoiding the organs at risk, selecting the appropriate treatment devices like wedges and things like that to help get a conformal dose over the entire treatment volume. So I think that the 3D plan was actually the most difficult for me. With the full arc and partial arcs, understanding the optimization tool was the biggest thing. Knowing how the constraints worked and how the computer worked and which numbers to put where as far as priorities and things like that. So it was interesting to learn how to do the full arc and partial arcs with the IMRT. Things that I learned during this case study was that there are many ways to achieve the same goal when creating a treatment plan, but some ways may have a slightly better outcome. And for example, it was the tissue sparing and less time on the table for like the partial arcs versus the full rotation arc and the 3D conformal plan.